Well, hello, it's Zane Horowitz and the crew at the Oregon Poison Center for the first of our academic season in 2023 Journal Club. It's September 7th, and we are talking about lab errors that made the diagnosis, or in some cases, made the misdiagnosis, or they had to be pulled back from invasive procedures and worse because some kind of a lab false positive created it. We're talking a lot about anion gap, but a couple of other cases as well. I'm going to start off, and these are all relatively short articles. I'm going to start off with an article entitled False Positive Acetaminophen Concentrations in Nicotinic Serum. So the answer is right there in the title, but just as some background, we can get acetaminophen concentrations by a couple of different methods. There's chromatographic techniques, and there's immunoassays, and there's spectrophotometric techniques. The sort of gold standard, which we don't use in most labs because it takes a lot of time, is high performance liquid chromatography, or HPLC. What we usually use is some sort of automated immunoassay or enzyme linked colorimetric method. I'm going to name the names of the machines because not only do they show up in this paper, but they show up in some of the other papers we're going to talk about as being a problem. So the two machines that they had problems with this case report I'll tell you about is the Cobas and the Artect machine. So let's get into the case. It's a 49-year-old woman who presented in a coma to an emergency department. Her friends and family ignored her comatose state for 4 days, and they assumed that perhaps she had been drinking because she had a known history of alcohol misuse. And by the time they brought her to the hospital, she had a Glasgow coma score of 3, a blood pressure of 75/55, heart rate of 92, and she was slightly hypothermic at 35. And she was jaundiced, clearly jaundiced. Her labs showed a bilirubin, and this is in micromoles, 442 micromoles per liter. Reference is usually less than 17. An alk phos of 456, a GGT of 1,182, an AST of 129, an ALT, which was normal at 43, so just the AST and GGT were elevated, and an acetaminophen concentration was 81 micromoles per liter. Again, that's how we usually do it, the normal being up, therapeutic, up to 45 micromoles. So figure that's about twice what we would consider upper normal using micrograms. Of course, what are you going to do with elevated liver enzymes, transaminases? You got to treat them with NAC, and she got treated with NAC. And again, the acetaminophen concentration was measured on that Cobas 6000 machine. And after a treatment with NAC, it was down to 11, and this was now back in the range we think of in micrograms per liter. And then 4 days of daily levels, her levels were 11, 12, 11, 12, 11, 12. And they were wondering what was going on. So they ran the acetaminophen concentration through the Architect C8000 machine, and it too gave an elevated acetaminophen concentration. So they finally went to the gold standard, the HPLC, and sure enough, there was no acetaminophen whatsoever in her bloodstream. So what was the problem? Problem was she was liver failure, and she was icteric, and she had hyperbilirubinemia. And bilirubin is a considerable potential for interference with all the spectrophotometric measurements. I'll go through one. Basically, it's an enzyme-linked colorimetric method, and it relies on the hydrolysis of acetaminophen to yield p-aminophenol. This is what the Cobas machine uses. And then that reacts with another dye to be blue-colored, and it's linear. And in the presence of O-creosol as a pyridate catalyst, it somehow gives you a numerical number. Now, all that details is not terribly important. I think what's important is that bilirubin in 2 of those 3 machines causes an interference. And in fact, there was no acetaminophen probably whatsoever in her system. So sort of the punchline and the warning of this article is that if you think that your acetaminophen concentration is not changing, especially in the presence of sort of elevated bilirubin, you need to use an HPLC method to prove or disprove, in this case, again, a false positive lab error, and she was treated for probably a few extra days that she didn't need to be treated with. So that's one acetaminophen story. We don't have any others here today, but we're going to jump around a little bit. We're going to talk a lot about things in basic chemistry. So everybody comes in and gets a chem panel. And one of the things that often gets everyone's attention is when the creatinine is really elevated. So to tell us about a few problems with creatinine is our fellow Colleen.
Hey, so I will first be presenting a little article that is Intoxication with Nitromethane Containing Fuels. Don't be fueled by creatinine. Very punny. So the abstract is case series, 2 patients. One had ingested nitromethane intentionally, and the other was a drag racer that had become soaked in the fuel after a crash, in which he was a polytrauma patient. So both patients were in their, early 20s. The first lady, 23-year-old, had more or less unremarkable labs, with the exception of a creatinine of 17.9. She had some send-out labs that hadn't resolved, but with her creatinine of 17.9, she was medically cleared to be changed over to a psych unit, which I thought was interesting. And then several hours later, her methanol level came back elevated at 89, so they removed her back to the emergency department. And she developed blurry vision and was given hemodialysis, after which both the methanol and the creatinine levels went back down. And the second case was the 25-year-old male crashed his vehicle going almost 300 miles an hour, broke a lot of things in his body, but his labs were remarkable for a creatinine of 8.6, which over a couple hours went up to 17.5. In both of those cases, patients had normal BUNs, normal electrolytes, just the creatinine. So what both of them had in common is their creatinine was tested by, I'm not sure about the pronunciation, I believe it's the Jaffe reaction, which is a colorimetric test. There is an enzymatic assay, but it's not nearly as used because it costs a lot more, and so money wins out.
It'll be a recurring theme a little bit.
Yeah, so the Jaffe reaction is extremely old. It was invented in like the late 1800s, and essentially you're combining your creatinine with picrate and then seeing what color, I believe it's like around red, 500 to 530, and if it makes this particular color, then the machine reads it as creatinine. Unfortunately, there's a lot of different things that will react with the picrate and cause that same reaction, and one of those things is the nitromethane. So the folks in this study did some nice experimentation looking at the false reading of creatinine in combining nitromethane with the picrate, and found that the very nice elevated levels that were drawn over time on both of these patients, there's almost like a one-to-one reaction of the nitromethane. So those levels of 17 point something, it's likely that their creatinine was completely normal, and that pretty much entirely what was being read as creatinine was in fact the nitromethane. I don't think in either case patients got treatments they didn't need, because you do need hemodialysis for nitromethane when it starts becoming methanol and giving you methanol toxicity. But you don't want to end up going down the rabbit hole of looking for kidney failure when you should be looking for toxic alcohols. And I think want to go on to the other paper that kind of dovetails into this.
Right. I'll just briefly mention that some of the different fuels for model airplanes and model racing cars and actually big track cars actually do have some methanol in it. So if there's an intentional ingestion, you'd have to check, like they didn't look too carefully or wait for the lab to come back in the first case for the methanol concentration. That was about 40% methanol in that case and about 35% nitromethane. So it's just a marker for the other. But if you're sure that there's no methanol, don't panic with the creatinine in the teens. If everything else looks good.
Yeah. Interesting that they medically cleared her with a creatinine of 17.
Mm-hmm.
But
Personally enjoyed the understatement of the year. His dragster underwent structural disintegration upon reaching approximately 290
Yeah.
miles an hour.
yeah, that's some nice
Way
language.
to put it.
I did have one case of this that was a very small child who got into the model car fuel, and he really, it was one of those where, like, did the kid really get anything? Probably not. And his creatinine was like 3.5. And so I had read these cases where the creatinine's supposed to be 20 or whatever, but it was like he really probably just got a tiny little bit, and then so his creatinine was a tiny little bit elevated, and then it cleared in 2 hours.
But there's no other reason for him to have a creatinine of 3.
Yeah,
so.
exactly.
Yeah. So whenever we get those labs and they panic call, that's one of the questions we ask. But there are other things that cause a false estimate of creatinine you'll tell us about.
There is a number of them. So as with most colorimetric testing, anything that causes the machine to read the right wavelength of light is going to be read as whatever the machine is programmed to read, which in this case, if it's reading 500 to 530, is going to be creatinine. Unfortunately, there's a lot of different things that can either cause that reading to go up or go down. If you're specifically talking about that colorimetric Jaffe reaction, which is the most common. I was surprised by the number of things on this list. Looking at the paper Positive and Negative False Estimates of Serum Creatinine, published in Interventional Cardiology. A lot of the cephalosporins can cause increased like positive interference where your creatinine might get bumped a little bit. And there's a lot of medications that, the creatinine isn't falsely elevated. The creatinine, there is an increase in the creatinine, but it's because the tubular secretion of the creatinine has gone down, so you're keeping more of it, but the GFR has not actually changed at all. So usually we're using creatinine as a rough measurement of GFR, but just because your creatinine is up doesn't mean it's because your GFR isn't, functioning correctly. Whether that's because you've eaten a bunch of beef and now your body is just full of exogenous creatinine. Well, your kidneys are doing their job just fine. You just have given a little extra load to your body. They went over a bunch of different mechanisms, like the eating meat, adding exogenous, decreasing your secretion while leaving your GFR unchanged, and then some things that are truly, colorimetric interference, such as the nitromethane. I'm not sure how much specificity you want me to go into through this list of many, many substances.
No, a couple of ones that we certainly care about in tox, such as aspirin and acetaminophen.
Yeah.
Both can interfere with the Jaffe reaction.
Mm-hmm.
Conversely, what we just talked about, bilirubin actually causes negative interference, so your creatinine will be falsely suppressed in an enteric serum, so it won't reflect true level of renal function. So these are things sometimes that give us a clue to what's going on.
I guess we didn't really talk about the enzymatic reaction, because that is a lot less frequently used because of cost and the amount of time that it takes your laboratory workers to go through the process, where you're actually using, I believe, one of the creatinase enzymes to turn your creatinine into creatine and then do some more chemistry with it. So it's got, in general, a lot fewer false interactions because of the specificity of the enzymes. But there were still medications here, such as lidocaine and flucytosine, that can cause positive interference with your enzymatic assay. So,
Yeah. And often the physician and the nurses and everybody else doesn't know which one's being used by the lab, because we just don't.
Oh,
It's
no.
just true. That's what it is. So when you have these things, you probably have to talk to the lab technician directly and ask them which method they're using in order to help figure out if you're dealing with a true positive or a true negative or some kind of interfering substances. So don't be fueled by the creatinine. I usually don't like punny ones, but that one helps you remember what the agent involved is. All right, moving along, and some of my favorite topics in the anion gap is pseudohypochloridemia. Emma's going to tell us about a few different cases of that.
Okay. I'm going to start with a case report from the legend B. Zane Horowitz. This is a classic one that we talk about a lot here at the Oregon Poison Center, which is bromism from excessive cola consumption. A really interesting case, and I love how the case really goes through how this guy came to the hospital over and over and over again, and his chloride levels that are just absolutely sky high were completely overlooked. So this is a case of a 40-year-old male who was otherwise healthy. And I'll just start at his first presentation, which was 30 days before the eventual admission that got him diagnosed with bromism. So 30 days previously, he came into the ED with a headache. He got a CT scan, and it was equivocal, I guess, for a subarachnoid hemorrhage. So he came in, and he got CSF, which didn't have any blood or xanthochromia, and he got an MRI and an angiogram and all this, and they discharged him 12 days later. At this point, the admission serum chloride was 152, and when he was discharged 12 days later, his discharge labs had a chloride of 115. So 2 weeks after that, he comes in also with a headache and some lethargy. Again, he gets repeat lumbar puncture. He gets another workup. It's negative. He goes home. At that time, his chloride was 132. He goes home on pain medicine for his headache. So the third presentation, he said, the headache had now resolved, and now he can't walk. So I always say that for an adult, if they really want to stay in the hospital, all they have to say is, I can't walk. If you could walk yesterday and you can't walk today, then you get to stay, right? So he couldn't walk, and he comes in. The family says he's losing his memory, he can't concentrate, he was having trouble with coordination. On further history, they find out that he had a bout of diverticulitis, which required a colostomy, a diverting colostomy, and he had since then had chronic diarrhea and a large weight loss. What was interesting is that over this time, he stated that he consumed 2 to 4 liters of this discount store cola brand over these last 6 months. And so he wouldn't drink the cola while he was in the hospital, but as soon as he got home, he went back to his cola habit. So on his exam, vitals were normal. He could not stand unsupported. He had ptosis of the right eyelid, and he was kind of diffusely weak, poor coordination with no focal motor deficit other than this right-sided ptosis. On this final arrival to the hospital, his chloride was 130, and his anion gap at that time was negative 16. His osms were normal. Eventually, somebody called the Poison Center, and they recommended that they get a serum bromide concentration due to the negative anion gap. And the bromide concentration was 3,180 milligrams per liter, which is quite elevated. So he was treated with fluids, but he didn't really improve. His serum chloride, interestingly, was fluctuated and actually went up a few days after a few days into just fluid resuscitation, and his chloride went up, but his serum bromide at that time actually had started to go down. It was 2,800. So the half-life of the bromide at this point was 11.6 days, if you calculated it out. So basically, they decided to do hemodialysis, and right after 4 hours of hemodialysis, the chloride read 116, but the bromide level came down to 377. So the hemodialysis, the half-life of the bromide during hemodialysis was 1.38 hours, very much quicker than just with fluids. And the best part of the case is that after hemodialysis, the patient dramatically improved with complete resolution of his ptosis, his lethargy, and his ataxia. He had a little more dialysis while he was admitted, and then he went home normal. So I really like this part. They found an empty discount cola bottle, and listed in the ingredients was brominated vegetable oil. They asked the store about it, but the store pulled all the cola from its shelves and refused to allow testing. So I guess we'll never get to test the brominated vegetable oil cola. So the discussion talks about different kind of places you can find bromide. More or less, these were in medications a long time ago as sort of sedative hypnotic drugs, and people would get bromazine just from long-term overuse. So the half-life of bromide is just very long. So if you're using these drugs too much, it easily kind of adds up. There's also some bromide in dextromethorphan and a couple of other drugs, which maybe if you took a lot of dextromethorphan over a long time, you could get some bromism from that. And so basically what tipped off the providers in this case was this negative anion gap, and this massive hyperchloremia that just kind of doesn't make sense, right? Why would someone have a chloride of 150? So the reason that this happens is the bromide interferes with most commonly used assays for chloride. So it produces this factitiously elevated level. Hyperchloremia alone is a very rare laboratory abnormality, which could happen in a normally metabolic acidosis, but probably not up to 150. So in almost every case report in the literature, including this one, the diagnosis of the bromism was very delayed, despite oftentimes this very sort of obvious hyperchloremia that doesn't make sense. And so sort of treatment for bromism is you try fluids. If fluids doesn't work, there's some reports of mannitol or loop diuretics, and then eventually hemodialysis. There's no specific recommendations for hemodialysis based on the bromide levels or symptoms or chloride levels or anything like that. So it seems like it's clinical judgment. But this guy was clearly very toxic and improved very dramatically. So that's sort of a baseline. And then I've got another interesting case, which was an ethylene glycol poisoning with a normal anion gap due to an occult bromide intoxication. And so this patient, similarly, the bromide was sort of, the brominism was being hidden by this ethylene glycol poisoning. So 39-year-old woman, found unresponsive. She was extremely acidotic when she came in. She was basically GCS3, tachycardic, Kussmaul breathing, and her ABG had a pH of 6.85, PCO2 of 11, and she, on her BMP, she had a chloride level of 122. This was measured colorimetrically. And she had an anion gap of 8.9, so a completely normal anion gap. They were very suspicious of ethylene glycol, but they weren't able to get an ethylene glycol level. So they tested her urinary oxalate excretion, which was elevated, which fascinated me that they could not get an ethylene glycol level, but they could somehow measure the oxalate excretion in her urine. Okay, that's fine. So yes, they're super suspicious for this ethylene glycol, but they couldn't prove it, and they had a normal anion gap. So the way they make it sound is it made them sort of second guess themselves. Like, could this possibly be an ethylene glycol ingestion that comes in with this normal anion gap, despite the fact that she had a massive metabolic acidosis based on her labs, or her ABG. So they treated her with bicarb. Her pH, they couldn't really get her pH up. They repeated all her labs, and her chloride is now 127. And finally, her anion gap did rise to 26. And they got an osmolar gap of 20. So they decided that they should just go ahead and do some hemodialysis. She improved, and then she said, yeah, I drank a bunch of antifreeze. At the time of her arrival, though, because of this unexplained hyperchloremia, they decided to send a bromide level, and the bromide level eventually came back at 175 milligrams per deciliter. Now, if we compare this to Zane's case had 3,000 milligrams per liter. This lady had 175 milligrams per deciliter, so that would be 1,750 milligrams per liter. So similarly, quite elevated, definitely above toxic level. And so the bromism that she was suffering also kind of cleared when they did hemodialysis for the presumed ethylene glycol. They never got an ethylene glycol level. But maybe she didn't even drink that much. So more or less, they got this patient. They were so suspicious of ethylene glycol, but they had this normal anion gap, and they had this elevated, unexplained hyperchloremia, which is kind of what tipped them off. So they just make the point that, the neurologic signs of bromism, agitation or psychosis or tremors or ataxia wouldn't be apparent in a patient with, who's altered from polyingestion. And so this inappropriately normal anion gap, which is sort of the equivalent of a negative anion gap in another patient, in addition to this unexplained hyperchloremia, sort of tipped them off to think, oh, hey, maybe there was some brominism at play. So that's our second bromide.
The key is in both of those cases, and multiple other ones that are in the literature, like chlorides, which if you ask a bunch of people what the normal chloride is, they probably wouldn't be able to tell you what the upper limit of chloride is if you just asked that. But it's only about 105. It's sometimes even lower in some labs. So when you see 122, it doesn't register a lot of times, but 122 and 150 are outrageously elevated chloride levels, and it will pick up chloride, fluoride, bromide, iodide.
I think I've had a patient that had a chlorine measured in the 120s that had a bunch of dextromethorphan.
Yep.
There it is.
A lot of bromide in dextromethorphan, bromide, which is the salt.
Go figure.
But there's one other reason for pseudo-hypochloremia, and it's the last case report you have there.
Okay, so this was a pseudo-hyperchloremia caused by a sodium nitrate ingestion. This is sort of a more recent topic. We probably won't see that much Romanism because you can't get those sedatives anymore. So it sounds like they worked quite well. But nowadays, many people do try to injure themselves by consuming sodium nitrite, which is a meat preservative that you can easily buy online. And due to the similarities in nomenclature, patients sometimes mistakenly get sodium nitrate. Interestingly, I mean, if you take enough sodium nitrite, you're probably extremely ill and might not make it to the point where someone is thinking hard about your lab values over time. So, but if you take sodium nitrate, some portion of that nitrate is converted to nitrite, so you might get sick, but not as sick. And of course, that causes methemoglobinemia. So this 29-year-old in this case took sodium nitrate in addition to a bunch of their home medications, including quetiapine, escitalopram, zopiclone, lorazepam, et cetera, et cetera. So they came in a little hypoxic, a little tachycardic, and normal blood pressure, some ataxia, hyperreflexia. And they got, they initially got labs on something called an ABL 800 blood gas analyzer, which is a radiometer. And this showed a chloride level of 167, with the remainder of the values fairly slightly abnormal, a little hypernatremic with sodium 163, hypokalemic with potassium of 3.2. The pH was 7.3. The methemoglobin was 9.4, so a little bit elevated from the nitrate, but not so much that it required any intervention. But it was interesting that this chloride was 167 with a negative anion gap of negative 35. So the patient remained in the hospital and the neurologic deficits resolved. And so looking at this chloride, they suspected that this was artifactual because the patient had a normal pH. It wasn't a metabolic acidosis, anything like that. So under this suspicion that this was an artifact, they ordered formal chloride testing on an Abbott machine, which is a redox reaction. And then they did mass spec as well. And they did serial samples and tracked out what the chloride level was. And so they see on this radiometer, which is sort of the point of care machine, the initial chloride was 258, and then it goes down to 200, and then down to 170, and then down to 154. But if you look at the mass spec numbers, the chloride is normal the entire time. It's like 95, 96, 102, 94. So these levels are all normal on the mass spec and on the redox machine. So their suspicion is that the nitrate present is interfering with this machine, and it interfered proportionally less as the patient was clearing the nitrate in their system. The positive interference becoming less evident as the nitrate toxicity resolved. So they didn't have patients' plasma nitrate levels, so we can't prove a linear correlation, but it kind of makes sense. So their theory on how it was causing this is that the redox electrodes on the Abbott machine, they generate and I kind of was reading on the Abbott website sort of how this works. because this is sort of like those iStat machines that we have, is like you put the blood in and it goes in these little slots, and then you put that in the machine, and the blood never enters the machine. It's that there's a membrane, the redox electrode generates a potential when solid state silver reacts with the ionic chloride, which precipitates silver chloride. So the nitrate won't react with the silver because the nitrate isn't soluble enough to do that. And so it didn't interfere. So it didn't interfere with this Abbott machine. But in the radiometer machine, which was this point of care machine this other point of care machine they had, there is a membrane electrode which relies on ion exchange to selectively transport chloride into some electrolyte solution. And this chloride movement produces a voltage that is, proportional to the amount of chloride in the sample. So basically, because this voltage is just relying on ions, it can be interfered with by the nitrate, the same way that it would be interfered with if it was iodide or bromide or something else. And their theory is that the nitrate is more hydrophobic than the chloride, so it actually it moves into the membrane faster or something. So that is their theory, unproven because we didn't have nitrate levels, but they have this very nice chart of the falsely elevated chloride slowly drifting down over time, and these mass spec numbers that are staying exactly the same. So I think I'm sold, even though I don't 100% understand how these machines work.
And again, it's up to us, or to maybe ask the lab, like, what machines interfere with chloride. More likely than not, when you have an elevated chloride, it is probably a false positive and not a true hyperchloremic, because there are very few honest hypochloremic states that occur, disease-wise or otherwise.
Right.
So.
I am a little interested because it's not that uncommon that we get patients with nitrate toxicity and methemoglobin levels. And so I now want to put this in the back of my head the next time I get a nitrate toxicity to ask for the chloride level, because probably when we get a call at the poison center for a nitrate and they've got a methemoglobin level, I might not ever ask for the chloride level, right? Because we're a little focused on the methemoglobin. But
yeah, well, again, hyperchloremia, one of the things that messes up your anion gap, and certainly if you see a negative anion gap, it almost always is hyperbromism, or in rare cases, hyperiodinism, which is even more obscure.
haven't had one of those yet, but there's time.
But in your second case, they talked about how they almost missed the diagnosis, but they were thinking about it of toxic alcohol ingestion. So we move on to our next group of cases that were published back to back with sort of opposite issues having to do with actually getting that ethylene glycol level in two different children and with two different results. So Kiahi, tell us about those.
Yes, I feel like these are the most like crime podcast style cases. So we'll start with the first one, which is mysteriously titled Misidentification of Propionic Acid as Ethylene Glycol in a Patient with Methylmalonic Acidemia. So this is a 3-month-old with 1-day history of feeding intolerance, lethargy, and tachypnea, and was actually brought in kind of obtunded, very ill-appearing, and was initially diagnosed with otitis media. The labs did reveal an elevated anion gap metabolic acidosis with hypoglycemia, so the patient was started on a bicarb infusion and admitted to the PICU where they recovered. And on the second day of hospitalization, they sent the labs out to this independent laboratory who reported back that the serum acetone level was markedly elevated and the ethylene glycol was 180 milligrams per liter. So obviously this being that elevated automatically kind of set off the alarm bells. The child was put into protective custody and went home with the foster family and due to obvious concerns of mistreatment. 8 weeks later, the child came back to the ED, the same general picture. The ethylene glycol from that lab again was showing that it was 911. And this was reportedly after there was a unsupervised feeding by the biological mother. So, the patient ended up getting started on an ethanol infusion and was dialyzed, but unfortunately passed and was declared brain dead 3 days later. As a direct consequence, the mother was imprisoned for first-degree murder. However, the wrinkle and the only way that this came to light was the mother in prison had a second child who had the exact same manifestation shortly after. So this second child came in with an acidemia, altered mental status, and was eventually diagnosed with a B12 unresponsive methylmalonic acidemia, which is one of the many inborn errors of metabolism. And so the authors went back and got the serum from the first child's case and retested that and found that yes, indeed, that was actually more consistent with methylmalonic acidemia and not ethylene glycol poisoning, which is just a wild story. So what exactly had happened, and what was the whole point of this article was that the first patient's serum was measured by gas chromatography, and we have these figures here, which I can pull up, and for the people who are not able to see it, describe it. So the first figure is basically a series of spikes that were generated from the gas chromatography. The solid line was the patient's sample, and they had superimposed over it a dotted line of basically an ethylene glycol sample to kind of put the two in comparison. And so what they're trying to show is that the ethylene glycol spike is very near the propionic acid spike, where ethylene glycol, of course, is the toxic alcohol, and propionic acid is a metabolite that is part of the many indicators that lead to the diagnosis of this methylmalonic acidemia. And both of them have this second tall spike at the end of the spectrum. So taken together, it's pretty, well, it's not easy, but it is understandable how this gas chromatograph could be interpreted as an ethylene glycol poisoning. And the way that we get this information through gas chromatography is basically the sample is put into a machine that is assessing the components based on their volatility. So the sample is effectively vaporized, and the way that they interact with the various sensors and polar solutions used by the machine is reported out in this graph of multiple different spikes over time. So methylmalonic acidemia or methylmalonic aciduria is an autosomal recessive condition where the enzymes responsible for amino acid and fatty acid metabolism are deficient, and methylmalonic acid builds up. But propionic acid is the precursor to methylmalonic acid, so that too can start to accumulate, especially when the child is not really maintaining their nutrition. The treatment for this is actually a low protein diet and carnitine supplementation. And so in this particular case, if that goes undiagnosed and we don't address that appropriately, the acids build up, these children get very sick. So presumably what happened was, in this case, the child was getting to that end of the sick spectrum, the propionic acid was accumulating and creating this gas chromatography spike that looks very similar to an ethylene glycol kind of spike that led to the misdiagnosis. But then also the salvage diagnosis, because what I believe was the way that they actually are supposed to diagnose it is by using gas chromatography and mass spectroscopy, because mass spectroscopy looks at the actual mass of the compound, and propionic acid and ethylene glycol have very different weights, and so that would help kind of separate the two in order for us to get this appropriate diagnosis. So that was the first case. The second case was kind of...
And I'll just add that they
Yeah.
did a sort of a proof of concept. They
Oh,
didn't
that's
do it themselves, but they had a lab worker send their blood, and they purposely mislabeled the blood as pre-dialysis and post-dialysis and sent it to a couple of labs. And sure enough, after they spiked those samples with propionic acid and not ethylene glycol, all the samples came back positive for ethylene glycol from 2 different labs. So this would have been a common yet recurring false positive.
Yes. So we can somewhat understand the mistake that happened. Yeah, so the second case is kind of the flip side to that.
You should be more alert for ethylene glycol being not the problem, right?
Correct.
Except
In the situation where it is. So a 6-month-old girl in the second case showed up, decreased activity, increased irritability, poor feeding, decreased urination, vomiting, lethargy, pale, very ill-appearing child. They also had an elevated anion metabolic acidosis. They had hyperchloridemia, hyperglycemia, and a urinalysis that was kind of vaguely positive and concerning for UTI. And so they got started on a bicarbon fusion and started on antibiotics. And it resolved by hospital day 2 when she was discharged, on hospital day 5 just being considered a UTI. But to be kind of complete and well-rounded, they did send off plasma and urine organic acid screens on those day 2 labs, and she was getting better. And at that time it was negative except for some evidence of glycine and urinary dicarboxylic acids. And so just kind of this vague finding that they weren't quite sure what to do with. So they just called it a UTI at the first visit. 6 days later, the patient comes back for exactly the same presentation, was recovered under the exact same treatment, and this time after discharge, they sent her for outpatient workup of organic acidemias, acidurias. And again, the initial workup wasn't very revealing, and a presumptive diagnosis of a fatty acid oxidation defect, yet another inborn error of metabolism, was diagnosed, and the child's diet was readjusted. And the even more falsely reassuring element of this was nothing happened for another 2 months, so it kind of seemed like maybe we had found the answer. But 2 months later, the patient returned again, severe metabolic acidosis, and everything, pointed towards a very ill acidemic child. But this time, they actually sent the samples from day 1, while the patient was still in the most critical part of their illness. And this one actually ended up showing that they had glycolic acid, glycine, and then urine samples demonstrated oxalate crystals. So they sent that off for confirmatory testing, and the ethylene glycol concentration was elevated. Law enforcement was involved, and they got 2 bottles of formula at home that were intended obviously for the child, and they found that those had been spiked with ethylene glycol. The parents were never really the chief suspicion of this, but they noted that every time the child got sick was coordinating with the babysitter's schedule, and so that babysitter was fired. No, I don't. Based on how they wrote the article, this never resulted in any sort of legal action against the babysitter, but the babysitter never came back, and as far as the authors knew, the child did not have to go into the hospital anymore. So, what happened in this case, unlike the first one, is like the exact opposite of, we did an entire workup, we found that elevated glycine, this must clearly be a organic aciduria, but that obviously it wasn't, it was ethylene glycol poisoning. And so the authors felt that what had actually happened was all of the testing for the organic acidurias, and the metabolic abnormalities were all done when the child had recovered, when the child was no longer symptomatic. And so we're basically detecting the delayed metabolites, in a sense, of the ethylene glycol. And so their kind of position was that these patients need to have their testing early on, kind of the oldest possible blood sample, in a sense, in order to really know what is occurring during the acute phase of their illness. Because unfortunately, as we know, all drugs and all these compounds can undergo metabolism, and once we no longer have the metabolite that we're looking for to test for, we can't really say that that's in there. And in this case, they were saying that the glycine was probably the or metabolite degradation product of the ethylene, of the glycolic acid. And so by finding it on those day 2, day 3, weeks later, all we were really finding was ethylene glycol, but we were misattributing it because that's not what we look for primarily.
So two, like I say, back-to-back sort of opposite cases, one where the guilty party never quite identified or at least prosecuted who was spiking milk with antifreeze. In the other case, the guilty, not so guilty mother sent to jail, but for the fact that she was pregnant and gave birth to a second child with the same exact metabolic disorder that was misattributed to ethylene glycol poisoning. I think the good news is, sort of to raise our awareness about this, but probably this may not happen as far as the misidentification of propionic acid anymore, because we have more sophisticated GC machines that actually the computer looks and compares the spikes based on a huge library of spikes, rather than back in the 80s when this happened, where the lab tech's lining it up against a sort of, well, it looks like where we expect a spike for propionic acid or ethylene glycol poisoning. So before we leave ethylene glycol poisoning, I'm going to talk about one more group of cases that have to do with that. And so turn to Kathy, who's going to tell us about those.
Great. So the first, hi Kathy, coming in from Zoom. So the first case that I want to talk about is it's ethylene glycol poisoning presenting with a falsely elevated lactate level. So this is a case of ethylene glycol poisoning where the patient showed falsely elevated lactate level, which was measured by a point of care blood gas analyzer in the emergency department, which are being used more and more. The specific machine was the radiometer. I think this is the same machine that was in Emma's case earlier. You'll be hearing that a lot soon. So they're talking about that this can lead to a misdiagnosis, but can also be used to identify ethylene glycol poisoning. So in this case, we had this 19-year-old kid who was found with decreased level of consciousness. It said he had many empty cans of soft drinks around him, wondering if they were Monster Energies, just personal wondering. On arrival, he was vomiting, lethargic, not following commands. Got a point of care blood gas on him using this ABL radiometer machine. His pH was 6.99, bicarb 1.5, PCO2 6.5, and they read his lactate as greater than 30, which alarmed everyone. I guess his chest X-ray was normal, EKG was sinus packed, they couldn't figure out what was going on. Then they got plasma testing that was sent to the lab, and his lactate ended up only being 3.2 on that testing. Also later revealed osmolar gap of 31, anion gap of 37. So they're now they're thinking ethylene glycol. Turns out his level, I think it was 1.1 grams per liter, 17 millimoles per liter, and he improved with hemodialysis. So what happens in this case? The authors are saying there's sort of two different ways to test lactate level. The main metabolism of lactate that I think that I was used to is like inorganic, the metabolism that you go to lactate to pyruvate using lactate dehydrogenase. And that's what the plasma test was using. That's what the lab test was using. The point of care was using lactate oxidase. There's another reaction where lactate oxidase metabolizes lactate to pyruvate, and it produces hydrogen peroxide, and that's what this point of care radiometer was measuring, was the hydrogen peroxide. What turns out is that glycolic acid, or glycolate, has a similar structure to lactate and can also be metabolized by lactate oxidase to hydrogen peroxide. So the elevated glycolate from the ethylene glycol poisoning was being metabolized by lactate oxidase to make hydrogen peroxide, and that's why this point of care radiometer test was giving these elevated lactate levels. So this paper, at the end of it, they sort of say that you can use the lactate gap, which is basically the gap in the lactate between the plasma testing and this point of care radiometer to maybe identify ethylene glycol poisoning quicker than you would have without it, because the ethylene glycol tests take a while to come back. So they're using that this couldn't lead to misdiagnosis, but it can also be used to aid diagnosis of ethylene glycol poisoning sooner rather than later. So in the second paper,
Yeah, I'll just add
very similar.
I'll just add that they note another study that was done, which is kind of interesting, also spiking blood to see what turned it positive and negative. They didn't do this, but it was in their discussion. But they spiked blood with glycolate, and that was positive for lactate, glycolic acid. And
Glycolic acid
it was
and
positive. Both of those
glycolate,
positive,
yeah.
But oxalate itself was not. So of the different
No, yeah.
metabolic end products of
The
ethylene glycol, it's 2 out of 3 cause problems. Anyway, go ahead, sorry. Next.
Ethylene, oxalic acid, it did not have an elevated lactate level, and neither did formic acid. I think that's actually in the other paper.
Oh, sorry. Yeah, you're right.
But the second paper, it has very similar cases, but they're actually experimenting to see which point of care meters will give this elevated lactate level, and which won't. So they had 5 different analyzers. 2 of them were laboratory plasma analyzers, and 3 of them were point of care blood gases that are commonly used in the ER. The ones they used were the ISTAT. They had the Bayer Rapid Lab 865, and then they had the Radiometer 700. And basically, this is where all the figures go in. Basically, they took all the metabolites of ethylene glycol. They took glycolic acid, glycoxylic acid, oxalic acid, and they threw formic acid in there for good measure, which is the metabolite of methanol poisoning. And they basically added them into all of the point of care meters. And they found that the radiometer point of care analyzer showed markedly elevated lactate levels, even with small amounts of glycolic acid. I think as small amounts of 5 millimoles per liter, that even made the radiometer have very high lactate readings. And again, it was glycolate and glycoxylate. I guess they were similar enough to both make the radiometer give high lactate readings. And again, oxalic acid nor formic acid altered readings at all. And also the Bayer and the ISTAT and the 2 plasma machines, they all showed less than 4, a lactate of less than 4, even with really high glycolate levels. So basically, and they had a similar result that they can use this lactate gap to potentially diagnose people with ethylene glycol poisoning sooner, just because the test takes so long to come back. So they had 2 different patients. The first case they had was the 49-year-old female who came in that that point of care radiometer read a lactate level of 42. They had surgery consulted because they were concerned with mesenteric ischemia. They were like ready to do a laparotomy on this lady. It seems like until they got the plasma level back in this 1.5, her care was greatly delayed because of this misdiagnosis. She was discharged after 2 weeks and was still dependent on dialysis when she was discharged. They compared that to the second patient that they had, where basically the second patient, they, as soon as they came in, they basically, where was that one? The second patient, they were able to pretty quickly recognize, trying to get that. The second patient, basically they came in and they, they used this lactate gap, and within 2 days, the patient was discharged with not requiring any dialysis. They were discharged and they were back to baseline within 2 days versus 2 weeks for the first patient who was misdiagnosed with the lactate. So they're basically, again, saying they can use this lactate gap to potentially have a faster diagnosis of ethylene glycol poisoning.
Yeah.
But you have to have that specific radiometer 700. That specific
I don't think it's the
radiometer
I don't think it's the only one. There's like 2 or 3, but they're all sort of the iStat or point of care instruments that often give you the false lactate. But you should obviously, if someone's lactate's in the teens or 20s, then it's not due to shock or sepsis, and we shouldn't go down the sepsis protocol. We should call Tox and let us sort out whether it's metformin, which may be one explanation, or it is a false positive lactate indicating this problem here. And we've had a case where they've called the surgeons first and done surgery or wanted to do surgery like they did in your case because they were worried about ischemic bowel or some other intra-abdominal catastrophe.
I was really shocked by that first case where they had the surgeons in before they even had plasma labs and a CT scan. The surgeons already came. I'm like, what hospital are they working at where that's happening? But but that's like surgeons wanting to operate without a CAT scan. I don't know. That seems wild to me. But I guess it happens.
Yeah. I know we've been in that scenario from time to time, but now we understand that the lactate in the point of care is not perfect for lactate. False negatives are found. Well,
You say lactates of greater than 30 doesn't necessarily mean esoteric ischemia. It could be, it could be metformin, it could be cyanide. Like there's so many other things. It could be not just mesenteric ischemia.
All right. Well, before we leave the anion gap behind, I want to do one more case. Something else that the anion gap sometimes refers us to, but there's a case of just the opposite, where the anion gap was not revealing in an aspirin case. So, you want to tell us about that, and then we'll introduce the other two as well.
Yeah, I have, the title is Negative Anion Gap Metabolic Acidosis and Salicylate Overdose, Zebra. So, this is there's a 30-year-old man. He presented to the ED. He had reported possible alcohol ingestion and overdose of Keppra. Patient was sweating. He required Ativan and Haldol to reduce his agitation. Sorry, I just lost my thoughts. Okay. So initial workup for him, his sodium was 146, his chloride was elevated to 118, carbon dioxide 21, urea nitrogen was 12, creatinine 1.0, anion gap was 7. And he had leukocytosis of about 14, normal hemoglobin and platelets. INR was 0.5. His VBG was revealing for pH of 7.4, bicarbo 14.5, and carbon dioxide of 24, oxygen to 88. So they did a tox screen on him. They found his salicylate level about 45.8 and It was positive for Keppra and CBC and ethanol. His anion gap was normal throughout the course in his at the hospital, even though he was acidotic and has a BMP and BBG. And at one point during the stay, his salicylate levels peaked at 81 after 8 hours at the hospital, and chloride levels also climbed up accordingly with the salicylate levels peaking at 121. So they immediately treated him with activated charcoal and half normal saline and bicarb. So this paper talks about how we could have missed a salicylate poisoning if they didn't test for that, if they just went based on, okay, he wasn't showing any anion gap elevation and changes in that, and he was just acidotic. So this was potentially due to the machines that test, like run BMPs. The hospital used the Simon's Dimension Vista analyzer, which happened to read the salicylate ions as chloride ions. So it was giving this falsely elevated chloride ion levels and didn't show the true anion gap that he potentially had. So this was the education point.
So yeah, I could have easily thrown this paper in with the pseudohypochloremia papers. This is really a overlooking of the chloride level, which went up to 121, but because of the individual machine they used, really what reflected salicylate toxicity, so which they almost missed. But nothing gets scarier than a salicylate level that's reported back in the hundreds. Sometimes it's not true. So tell us about those cases.
Yeah, the other cases, title was falsely elevated salicylate concentration in patient with hypertriglyceridemia. So this was, in this paper they talk about a 26-year-old man. He presented with diffuse abdominal pain and he had tachycardia of 110 but soft belly with my right lower quadrant pain. His lab results were significant for hyponatremia of 122, normal anion gap and bicarb and pH. But his serum triglycerides were 7,650, serum cholesterol of thousands. His ethanol and salicylate were measured because there was a concern for self-harm, and it was 13.1 and over 100 respectively. This was measured using the Simon's calorimetric method as well. So when they had this lab results, they consulted nephrology, and over the phone they thought they should activate charcoal and hemodialysis and transfer to like tertiary care. However, when the patient was evaluated at bedside, he was asymptomatic. He only had that abdominal pain that he presented with, and he didn't have the typical signs of salicylate poisoning. And quickly they realized this mistake was due to hyperlipidemia, so they stopped all his treatment they began for that, and they treated him with insulin infusion for his severe hypertriglycerides, and his trigs and salicylate levels dropped. Another education point was that usually salicylate concentration about 10 milligrams should have produced symptoms of those things that we expect, like nausea, vomiting, tinnitus, and tachycardia, and hypertrophy and acidosis, which he didn't have. The paper also mentions how there's multiple methods to measure, like the Trinder test, which combines the ferric ions with salicylates to produce a purple color. The other ones are fluorescence polarization immunoassay, which uses polyclonal antibody, and then the other one uses salicylate hydroxylase, which is supposed to be specific for measurement and has no interference with other stuff. The other case is pretty similar. This is a 38-year-old male, but he has past medical history of non-ischemic cardiomyopathy, hyperlipidemia, depression, hypothyroidism, and he was found to be altered mental status for 1 week. He had fallen multiple times, had like exertional syncope, worsening dyspnea for about 2 weeks, and his recent ejection fraction was 45%. He's on vast majority of medication like gabapentin, atorvastatin, buspirone, and furosemide, and digoxin and carvedilol. In the ED, his blood pressure was 60/31, tachy to 180, oxygen was 96. His physical examination was pretty unremarkable. He was hyponatremic as well, 114, hypokalemic of 2.8, and anion gap of 13. They measured his salicylate levels because he has a history of depression and suicidal thoughts, even though he denied any at the moment. It was salicylate levels 109, and APAP was 7.8. His pH was 7.48, and carbon dioxide was 41, and oxygen 61. They then called the poison center, and they recommended to do an alkalizing therapy and also transfer to a tertiary care for hemodialysis. But due to like this incongruity between his presentation and his lab results, they did a repeat salicylate, which was 77. At the tertiary center, he had normal vital signs. His sodium was 132 now, and potassium was 3.1. Anion gap was 18. ASD was 328, ALT was 109, but his APAP was 4.8 and salicylate was less than 5. They measured cholesterol and triglycerides there, and it was total cholesterol was 1,000 and hundreds, and triglycerides were in the 6,000s. So they realized that this is probably the reason why he had a weird elevation in salicylate. So they did supportive care and improved his transaminases, and he was diagnosed with orthostatic hypotension and hyperlipidemia and hepatic steatosis. So both of those facilities, they use enzymatic spectrophotometric light, but so usually what they do is if a patient found to have like hypertriglyceridemia, they use a lipoclear or they centrifuge, and they only use a fluid that's like doesn't have the lipid concentration because it affects the readings, and it can falsely have an elevated salicylate level. And then they called the other lab or the other hospital that had his sample from the previous time, and they did the delipidation step, and his repeat salicylate levels was less than 2.0. And they should have also, they mentioned how this should have been kind of a tip off because hyperlipidemia is also taught to like have pseudo hyponatremia, and his hyponatremia, like his sodium levels were pretty low in the first hospital as well. So that's what this paper talked about.
All right, great. Yeah, we've had other cases of this, and I don't know if you mentioned the lipoclear is the magic substance that you have to add in a light fatty serum to get the answer.
I imagine these labs are pretty obvious too. They usually sit, on a counter for a few minutes, and then you can see it all separated out.
Yeah.
So you can probably request that.
All right. Well, changing gears, a little bit more anion gap problems, and about this time focusing on lithium as the problem. So Joe, tell us about your two papers.
All right. So we'll start off with a paper that's titled "Reduced or Absent Serum Anion Gap as a Marker of Severe Lithium Carbonate Intoxication." Essentially, this paper talks about two different cases where there was either an anion gap of 0 or markedly reduced that patients presented with lithium toxicity. It kind of gets into the reasons why that may be. So just kind of as a reminder, our anion gap is our measured cations, which are sodium, subtracted by the sum of our measured anions of bicarbonate chloride. Normal somewhere 8 to 16. And then in regards to our lithium levels, anything greater than 3.5 milliequivalents per liter we consider severe toxicity, and as far as for the purpose of this paper. This case, so one case had a 64-year-old woman that was admitted for inability to ambulate and disorientation. She had a history of bipolar affective disorder, and she was on lithium therapy for the last 2 years. She was disoriented, had increased deep tendon reflexes and myoclonic jerks. Ultimately, she had a lithium level scent that was recorded at 4.5 milliequivalents per liter, and an anion gap of 2 in her case. She underwent hemodialysis and had resolution of her symptoms, and then also improvement in her lithium level from 4.5 to 0.9. Anion gap also normalized at that point to 7. In her case, the remainder of her electrolytes really were sort of unremarkable. Potassium of 4.3, calcium of 10, magnesium of 1.9, phosphate of 3, albumin of 8.8, and a globulin of 2.2. Case also discusses, there's a second case of a 33-year-old with a history of manic depression who had stopped taking lithium 2 months prior to her presenting because she developed nephrogenic diabetes insipidus at that point. And then on the day of presentation had a self-harm attempt when she took an unknown amount of lithium. It sounds like she was obtunded, had some moderate volume depletion on exam. She presented with a lithium level of 6.5 and an anion gap of 0. She underwent, it sounds like, 2 sessions of hemodialysis with improvement. Her lithium level improved to 1.5 and her anion gap increased to 6 at that point from 0. So she, ultimately her case, she ended up expiring due to some underlying pneumonia and then developed sepsis. So in this case, the serum lithium ion concentration was measured by flame photometry. They took 10 subjects and measured their therapeutic lithium ion concentrations. They had normal renal function, and they found that they had a mean anion gap of 8.5. In these 2 cases, in what is a severe overdose in both cases, with initial presenting lithium levels of 4.5 and 6.5 respectively, they had either markedly low or undetectable anion gaps. Otherwise, no other electrolyte derangements. There could be several reasons why somebody might have either an undetectable or a low anion gap. Paper discusses, as we kind of talked about, alluded to Emma's case before, in the case of a possible bromide intoxication, we can see something like this, or somebody with some sort of plasma cell dyscrasia or hypoalbuminemia, could also present with low anion gaps. It's interesting because lithium being one of the unmeasured cations, that could have an impact in having obviously a low anion gap. So interesting for us to consider in our differentials. Somebody that you may not be thinking of bromide intoxication, may not be thinking some sort of plasma cell dyscrasia or hypoalbuminemia, just something to keep in mind as far as potential for lithium toxicity in somebody with an undetectable or low anion gap. So two interesting cases where the anion gap could have pointed you into one direction to.
And it's never a negative number, it's just a small single-digit
That's right.
number.
That's right.
Just to be clear.
Yeah.
But sometimes you can go in the opposite direction falsely. So tell us about your other paper.
Oh yeah, so this is a paper titled Factitious Lithium Toxicity Secondary to Lithium Heparin Containing Blood Tubes. So this was a descriptive study that was triggered by, it seems like there was a case of a 12-year-old that had presented with a lithium level of 9.2 millimoles per liter, not showing any clinical signs of lithium toxicity. And ultimately, it was determined that the reason for that was that the patient had lithium level drawn in tubes that contained lithium that were bound to the heparin. So this case, this study took 2 different types of green top tubes, typical tubes that we would run sort of in our standard rainbow panel or Tox Labs, and measured lithium levels in patients, 5 healthy volunteers who had never ingested lithium, did not use any sort of medications, dietary supplements, vitamins, or any illicit drugs, and measured their lithium levels in these 2 different types of tubes. One tube contains 57 USP units of lithium. The second tube contains 72 USP units of lithium. And then they used a non-lithium containing control tube and also ran lithium levels on that. The result was, as we can see sort of in the table to describe it, they in their green top tubes, the two different tubes, they did 3 different measurements. They filled one set of tubes with 1 cc of patient's blood, one set of tubes with 2 cc's of patient blood, and then one set of tubes with full amount of blood. And we can see that lithium levels were markedly elevated in all of these patients, in these patients that are not on lithium, and inversely proportional the amount of blood that was collected to the lithium level. So the lower amount of or the smaller amount of blood collected in the sample had higher amounts of lithium, presumably due to the just relative blood concentration of the lithium in the tube to the patient's blood level. So, interesting. The control, essentially had an undetectable lithium level. There was a small amount, 0.16, which is interesting to sort of, probably within the range of error, I would imagine, in a machine like this. But certainly, this has tremendous, I think, impact on somebody that you are considering potential lithium toxicity to drive, maybe unnecessary procedures such as hemodialysis. There seems to be some sort of impact on the amount of lithium in these heparin-containing tubes, triggering the result that we're seeing. Values measured in a tube that had 1 cc of the patient's blood, values as high as 3.3 to 4, and then a full tube measuring somewhere between 1 and 1.5 for both of those tubes. So not insignificant. And then this a lab error? I think we can think about it as maybe it being contaminated more than it is a lab error, but something to be aware of if we are considering that sending a lithium level on someone. It may behoove us to find out what type of tube is being used, because it could falsely elevate somebody that may actually be therapeutic in their lithium and may have an alternate explanation for their clinical presentation. So,
yeah,
interesting.
So it's not a false positive, it's a true positive,
Yeah.
but a false diagnosis because you don't take into account the fact that it's lithiated heparin in green top tubes, which we always tell people not to use, but it's faster apparently to run a serum separator on a green top than a red top, and that's all what happens. So when we hear these cases where the lithium levels in the 3 to 5 range, the patient looks great, we should ask what type of tube before we recommend other therapies that may not be necessary, including dialysis.
There's a couple of interesting things about this. One, that they never got to 9, which is what their original patient. They didn't get anywhere close to 9.
Yeah.
So I don't know if it actually explains their original patient. That said, I don't know. I don't think our lab would ever accept a vacutainer that isn't full. They just toss them out. And this, I don't know if this is the reason or not, but I mean, they wouldn't run a sample with one. I totally understand why they did it for the research. I think it's totally appropriate and it makes sense, and it's interesting because proportions.
Of course.
But and I think that's the other thing is that a full tube, it shouldn't be really much more than 1, which is enough to throw off your diagnosis for sure.
Yeah.
But
Or
it shouldn't.
lead to an admission that you don't need for fluids.
Yeah, exactly. You can imagine if someone had a therapeutic lithium and then it's +1, that might lead you to do something totally different. So, but I did think it was interesting that they never got close to 9, and I don't know where that came from. It's pretty.
I don't know.
And I don't think they have lithiated heparin in like PD tubes, or I'm kind of curious how that could possibly happen, but anyway.
All right, and last, but certainly not least, is we get a lot of drug screens. And people ask us to get drug screens because they think it means something very important, but often there's more false positives on drug screens than there are true positives, except for 1 or 2 exceptions. But the one that trips us up or trips people up over and over again is the one we actually don't use, which is a drug screen for tricyclic antidepressants. So we have 2 different articles with 2 different cross-reacting substances here. Sammy?
It's all true. Yeah, the granddaddy of them all, the tricyclics. So, one of the most feared overdoses, really. So, I have a couple of papers here. One of them is from 1999, and it goes over a couple of case reports with the general theme being a false positive for TCAs led to a diagnosis of carbamazepine overdose or toxicity. So, yeah, you may be thinking, why are there so many carbamazepine overdoses? I had the same question. Turns out, back in 1999, at least near Kentucky, 70% of all pediatric overdoses were carbamazepine. So, but it's not something that I see often now, of course. So I'll just talk about the case reports first. So case one, they're all quite similar actually, but a 16-year-old with a history of seizures and tics presented after an unknown ingestion. They were found unresponsive. Vital signs, were essentially within normal limits, but they did have some decorticate posturing and some pretty mydriatic pupils, like 9 millimeters, that were slightly reactive. Their labs were otherwise normal for the most part. Their urine drug screen was positive for amphetamines, but later a TCA screen, which was sent, was positive. So I gather that back in the 90s, a TCA screen was a separate screen that was probably often sent. But like Zane mentioned, it's not like a common or typical thing that we send nowadays because they're not as common of drugs, I guess. So this patient became more somnolent. They got a GCS of 7 and were eventually intubated. CT head was non-diagnostic, but nothing super obvious on there. They were given charcoal after intubation and transferred to the ICU, where their exam was described as having roving extremity movements. They were hyperreflexic. They had ankle clonus. They had an upgoing Babinski. Some strange findings here. Their LP ended up being normal, and then eventually we got some more information. So the serum qualitative TCA screen was positive, but the quantitative was negative. So these astute clinicians, this prompted them to check a carbamazepine level out of concern that there might be a false positive going on. So carbamazepine was indeed elevated in this patient, and turns out that they had been off carbamazepine for almost a year. They had previously been on it, but doesn't really go into detail, but the patient felt that they were going to have a seizure, so they took an unknown amount of their carbamazepine prophylactically prior to that. So, yeah, the case, the report kind of left out some details that would have helped in a general case report presentation, but hey, the main point was there was a positive TCA screen, but negative quantitative with what ended up being positive carbamazepine level. Case 2, it was a 17-year-old that came in from an inpatient psych facility after an unknown ingestion. They were there for treatment of their bulimia. Their initial presentation was ataxic with dilated pupils, and the patient apparently stated that they took 15 Percocets that night between the hours of 5:30 and 8:45 p.m. So their exam, kind of suggested something maybe other than that, because they had this slurred speech, this truncal ataxia, this dysmetria, which is different than we'd think with a Percocet overdose. So they were, again, some screens were sent, including UDS, which was negative, but a separate TCA screen was positive. They were given charcoal, some decontamination, And eventually carbamazepine, with the same kind of thinking, carbamazepine was checked and was elevated at 18 micrograms per milliliter. This was now about 12 hours post-ingestion. So, of course, later they determined that they were not Percocets, they were carbamazepine tablets. The patient was clinically improved by the next day. So the third case, I'll go through that one briefly. It was a 10-year-old who was sent in from a community hospital. Their only drugs on the list were lorazepam for behavioral type issues. They took that 3 times a day. Apparently went to take a nap, and then later grandma heard some banging and ruckus going on in that room. Yes, and they found that the patient was altered, lethargic, complained of double vision, and they were just generally ataxic. The case report then documents that the patient went to the ED, had a GCS of 6, no clonus, and they were also ataxic. So I don't know, I haven't seen many GCS 6 people being able to test for ataxia, but hey, that's okay. Their CT head was also negative. Their laboratory workup again showed a positive TCA, but a negative TCA quantitative, prompting carbamazepine level, which was elevated. So this patient also improved by day 2, and then of course they find an old bottle of carbamazepine at home that was missing 33 200 milligram tablets. So, yeah. So then this paper goes over just shows a little table here that demonstrates. Here we go. This is what I'm trying to do. A number of, not that one. Yes. So a number of screens that we have for TCAs. They're medium, and then drug cross-reactivity for these tests. So you can see there's quite a number of false positives with different tests having different amounts and different drugs of false positives that can flag positive for TCAs. So, this one here, the SIVA emit, as you can see, has, let's see, 7 different known false positives. And we're going to add to that list too here in a little bit.
By far one of the more common ones too.
That's one of the more common screens.
Yeah.
Okay.
Yeah, it's interesting too that the only one that seems to trip in urine is cyclobenzaprine.
Yes.
All
Yeah.
the other ones, they proved that it cross-reacted on blood, but
Right.
I think that most of our testing that we do is usually a quick urine.
Right, and I think that's true now. I think, winding the clock back 2 decades, there was a lot of people who were getting qualitative or quantitative tricyclic screens because they were widely prescribed for depression. It's like before SSRIs really permeated the market. And people would get admitted because their tricyclic screening was positive, even though many of these drugs that you just mentioned, including carbamazepine,
So that was something
Yeah.
that could be
A
quickly
false
sent in the
actual
ED and
numerical number
come
for that
back pretty
screen.
fast.
At least get a semi-quantitative one. And urine, and anyone who's on therapeutic TCAs is going to be positive, so it doesn't help you for the overdose, but
Right.
you can get a quantitative or semi-quantitative.
Okay. And then, I always, whenever I hear the chromatography, I always think that that's the purest and truest. And, the gas seems to be pretty good. No reported drug cross-reactivity. But, some of these other, even chromatography methods do have false positives as well. Here we go.
And we make a lot of comments about like, so-and-so cross-reacts with this immunoassay, but I mean, one of the things you just showed was, it's really important to know your own, not necessarily the brand, but what are the false positives in your institution, because they are different in every place. And, just saying a raisin ham doesn't show up as a benzo, that's not necessarily entirely correct, and, might be false.
Yeah. So overall, this study, they made a couple other points in their discussion. They kind of highlighted particular levels that other studies have found to, correlate carbamazepine levels with certain symptoms, and in general, just to share for your guys' reference, greater than 85 was shown generally to have bad outcomes such as death. Greater than 28 in one study, and greater than 35 out of a group of Oregon. So I'm going to trust them. Was that
That was Bob
Norton? Oh my God. So Norton found that greater than 35 was kind of the level where you would expect major toxicity like seizure, coma, intubation. Overall, I always thought that concept was kind of cool. So the main point of this paper was like using the false positive to make a diagnosis of something else. And I think, there's a number of, there's one in particular I'm thinking of, like bupropion can cause a false positive for amphetamine. But this method is really only potentially helpful if the thing you're testing for is rare, and amphetamine is not that rare, or methamphetamine. So, but I can see how some things could be useful with this kind of method. All right, so the second paper I wanted to talk about was a group of very, very astute researchers, selfless really, sacrificing their own bodies for science. And this was about quetiapine false positives in screening assays. This paper used a case report that I'll go over here as kind of a to establish, kind of what the issue it was here. So a 36-year-old apparently called EMS 15 minutes after ingesting a large amount of quetiapine in a suicide attempt. They reported like 75 200 milligram tablets that of a prescription that they had just filled that morning. So by 45 minutes after the ingestion, the patient was already in the ED, and they were obtunded, but maintained a good gag reflex. Didn't look like they were intubated. Their vital signs showed heart rate in the 140s. Their blood pressure was 70s over 30s. Their pupils were kind of mid-sized but reactive. And then otherwise no other significant exam findings. They did end up putting a Foley catheter in, which showed, put out 300 urine right away. And then otherwise, as far as relevant workup, the EKG showed some QT prolongation 480. So this patient ended up just getting fluids and then went to the ICU, and they improved over the next 12 hours, over the next 24 hours, QT normalized. And then we get to the root of the paper here. Labs had shown a positive TCA screen, and the patient did kind of have some of these features that kind of mimicked TCA toxicity. But quetiapine levels were actually the ones that were elevated and not TCA. So quetiapine levels was like 70-100 initially, and then down to 4,200 after 4 hours, which kind of aligns with its volume of distribution in pharmacokinetics, while the TCA was not truly elevated. So this case prompted a study, which these two fellows ran. They designed themselves. And what they did was took urine sample from a patient who had overdosed on quetiapine, and then a patient that was on quetiapine normally, so like a therapeutic type of dosage patient. And then they created their own kind of urine concentrations by one specific researcher, Robert Hendrickson, provided the urine sample. It's published in there.
I feel like we should have left it mysterious. Could have been like guessing which author. I don't know.
Explicitly states.
A reviewer was like, "You must explicitly state." Good job.
Explicitly state the urine source for the presumed clean sample. So what they did was dissolved a 25 milligram tablet of quetiapine into this supposedly completely drug-free urine. I'm just kidding.
Let's just say quetiapine free.
Quetiapine free. I mean, yeah, water is technically a drug, I guess. But quetiapine free sample. They created various concentrations of this quetiapine solution so that they could apply the immunoassay, like 3 different immunoassays to each concentration in an attempt to see like what concentration flags a false positive in these tests. So they created dilutions of 1,000 micrograms per milliliter, 100, 10, 5, and 1. They used 3 different immunoassays, and it's a little bit easier for me to show the table here. Yeah. So, oops. And what they found. Where's my arrow? Okay. Yep. So what they found is, here are the 3 tests they used. The one on the patient in the case report was this microgenics test. Looks like the worst one, kind of, as far as false positive. And then triage and the SIVA. So, and then here is the overdose patient levels, which was 7.5, and the therapeutic was 0.2. So you can see that even on the lowest one, the lowest concentrations, 2 of these were positive for TCAs when they didn't truly have it. They just had the quetiapine levels in them. And then this triage one seems to be pretty false positive free as far as quetiapine goes. But so what's kind of interesting here is that the Sevia and microgenics, for example, were negative at 5, but here at 0.2 were positive. So this was the patient sample. So the drug had already been metabolized and have its metabolites, indicating that probably the metabolites are actually causing a false positive as well. And let's see if this, oh, okay, here we go. I just wanted to share a little thing of the metabolites, just so there's like 20 different, or like more than, at least 20, I think the paper said, metabolites of the quetiapine, and they all look quite similar. So you can fathom that they might cause a screening test to be positive with this pretty similar structure. So, stop sharing. So yeah, I mean that's really the main thing here, is that overall some urine assays gave false positives, likely due to the structural similarity. Yeah. So yeah, I thought that was a cool study design and interesting findings. Anything else? And for the podcast, what the original author is actually here with us. If there's any other
They survived
tidbits,
20 years drug-free.
Yeah, right, exactly.
if there's any other tidbits you want to drop in that.
No, I just think it was, you already touched on it, but I think the idea that there's a lot more metabolites than there is source material is important, because we often will only look at the original substance, in this case quetiapine, but 95% of the quetiapine-like substances in the urine are metabolites that we actually don't measure. So just something to remember, that a lot of these false positives, if you have a number, it's not going to necessarily match.
I think the good news is we mostly, I can't say every hospital in the country, or the world has stopped using this, but we mostly have stopped using it as a screen. And quite frankly, there's a lot of other urine drug screens that don't screen very well for the substance that we're looking for. We probably need to reevaluate what honestly we're looking for and why. The other thing I'll mention is that many of these studies were done, like they found a case and it was like, we almost blew it, or we almost dialyzed someone, or almost gave someone the wrong treatment, and then went back and they kind of self-experimented or spiked some samples of normal blood or urine and got an answer. Stuff we certainly could easily do with our lab colleagues, and we see other issues come up, because this certainly won't be the last group of things that cause problems and inconclusive lab tests. But these are the common ones we should be aware of as we go forward through the year. So thank you all for participating. It was a long journal club, but we'll see you all next time when we do this again. Thank you.
Stay